Well, hello and good afternoon. I'd like to begin by thanking the organizers for inviting me to speak and share this with you today, as I'll be discussing about FLIP, the functional luminal imaging probe for the study of esophageal disease. A couple of disclosures. And the FLIP is a device that can be placed into the esophagus at the time of endoscopy and utilizes impedance planimetry technology to measure the luminal dimensions, cross-sectional area, of a balloon attached to the distal end of a catheter as the balloon is filled with fluid in a controlled manner. And within the balloon is also a pressure sensor that allows for measurement of the dimension-pressure relationship, i.e. distensibility. And in addition to distensibility, we developed a technique to appreciate the dynamic changes that occur related to the esophageal response to distension. So the 16 diameters along the length of the FLIP, as well as the intrabag pressure, can be plotted over time and then interpolated to color-coded diameter topography in a similar manner to how esophageal pressure topography is derived from high-resolution manometry. Thus, this technique termed FLIP panometry to reflect its panometric assessment of esophageal function that incorporates esophageal distensibility of the EGJ, the body, and the dynamic EGJ opening and the contractile response to distension, i.e. secondary peristalsis. And therefore, the FLIP provides a method to evaluate both the mechanical properties of the esophagus as well as esophageal motility in response to distension. And further, our FLIP panometry technique was adapted into the real-time FLIP display that now provides real-time FLIP panometry data to assess esophageal distensibility and esophageal motility in response to distension at the time of endoscopy. This video here displays an example of the real-time display in an asymptomatic research volunteer. And as we see the normal EGJ opening, normal distensibility of the esophageal body, and this normal contractile response with this pattern of repetitive antegrade contractions, or RACs, which represents propagating secondary peristalsis that repeats due to the sustained distension created by the FLIP study. So how can this potentially be applied in clinical practice? I think about the utility of FLIP in 2 to 3 particular situations. First is for the primary evaluation. Most patients' initial evaluation for esophageal symptoms, particularly dysphagia, will begin with an EGD. Another clinical scenario is the utility of FLIP if the initial evaluation, potentially with manometry or esophagram, was inconclusive. And in this scenario, a second look endoscopy can potentially be useful and provides a potential opportunity to apply endoscopic therapy. In either scenario, the likely higher yield with the primary evaluation. If the EGD is diagnostic, such as reflux esophagitis or a large hiatal hernia, stricture, or EOE, a clinical diagnosis is reached and a management can be targeted. Though on a side note, there is a role for FLIP in EOE, and I'll briefly touch upon this toward the end of this discussion. However, if the EGD is normal or suggestive of an esophageal motility disorder, FLIP can be utilized right at the time of that initial endoscopy to evaluate esophageal motility, and in some cases, direct subsequent evaluation, such as reflux monitoring or manometry, or in other cases, it may direct therapy. An application of directed treatment, dilation, or botulinum toxin injection into the lower esophageal sphincter, which may be more likely in the complementary evaluation scenario, as FLIP can be applied to the prelim evaluation to help reach a clinical diagnosis. So just to review the FLIP study and protocol, performing the FLIP study is relatively simple and can be completed in 5 to 7 minutes at the time of the sedated endoscopy. The FLIP study to assess esophageal motility does require use of the 16-centimeter FLIP balloon and performance of a stepwise volumetric distension protocol while the balloon is positioned maintained in the distal esophagus across the esophagogastric junction. An interpretation of the FLIP is fill volume directed, and several factors for motility can be assessed, including the contractile pattern for response and metrics of EGJ opening. To assess EGJ opening, the FLIP utilizes a metric called the EGJ Distensibility Index, or DI, that is calculated as the cross-sectional area at the EGJ divided by intraballoon pressure. Additionally, we apply the maximum EGJ diameter, or the greatest diameter that is achieved in response to opening or in response to distension. And as we can see, this measure may alter depending on whether or not antegrade contractions are present, such as with normal peristalsis, or whether they are absent, such as in achalasia. We then interpret EGJ opening via a joint application of both the EGJ DI and the maximum EGJ diameter. And in part, we derived this scheme to try to avoid some of the limitations that occur with high-resolution manometry and the application of a single measure, i.e. the IRP, that has a singular cut point. Thus, when both EGJ metrics are distinctly reduced or distinctly normal, they can be classified as reduced EGJ opening or normal EGJ opening, as associated with a functional classification associated with a high degree of certainty. This, of course, does leave a borderline range in the middle in which some uncertainty persists. And in this scenario, complementary testing is likely warranted to help provide some additional clinical clarification. And from a clinical standpoint, patients with achalasia will nearly always have reduced, if not borderline EGJ opening. Borrowing data from a study here, we can see that in over 99% of patients with achalasia, this will be the case. On the other hand, normal EGJ opening will have an exceptionally high negative predictive values and can nearly always rule out achalasia. Secondary peristalsis can also be classified as we've observed specific patterns of the esophageal contractile response to sustained esophageal distension in a fashion that is fairly amenable to simple pattern recognition. Asymptomatic controls and the majority of patients with normal peristalsis on manometry will have a normal or a borderline contractile response that includes antegrade contractions, with the rack pattern reflecting normal. On the other hand, patients with abnormal peristalsis are more likely to have an impaired or an absent contractile response. Additionally, there are other features and patterns, such as sustained non-propagating contractions of the LES in response to distension, or repetitive retrograde contractions that may reflect a spastic motor response. However, secondary reactions to mechanical obstruction or hiatal hernia are also possible with these, thus we've labeled them as a spastic reactive contractile response. Ultimately, we can pull this together and apply both EGJ opening and the contractile response to distension to assess esophageal motility. So data obtained at the time of sedated endoscopy using flip panometry. And this we published a few years ago, and so this reflects slightly different techniques than I've just described, but still applied using a hierarchical fashion of esophageal motility with flip panometry, somewhat similar to the Chicago classification with high-resolution manometry. And in this study, we evaluated 145 patients that were studied for dysphagia with flip during endoscopy and high-resolution manometry. And among those patients with an abnormal manometry, which was the majority, 95% also had an abnormal flip panometry. And included among these was all 70 of 70 achalasia patients included in this cohort. Thus, we concluded that flip could effectively identify major motor disorders, particularly achalasia. Further, a few patients had an abnormal manometry, but normal flip, and these were all manometric EGJ outflow obstruction, so actually a clinically inconclusive, even if abnormal manometry. And I'll expand upon this scenario in a few slides. And among those with a normal manometry, we actually found that while half of these patients also had a normal flip, the other half had abnormal responses to distension on flip. And this suggested that flip could potentially detect functional abnormalities that were not detected among these symptomatic patients on high-resolution manometry. So an important aspect to consider is that esophageal manometry and flip panometry do measure different components of esophageal function and thus are not the same. Manometry assesses the response to swallows, and flip assesses the response to distension. Also, manometry is measuring pressures, which generally requires contact pressure on the catheter, whereas flip is directly measuring opening, which provides more of a biomechanical assessment of the esophagus. So there are certainly scenarios where they are overlapped between the two technologies as they have shared features, but there are times in which the responses may differ because of the different aspects of function. However, a few key takeaways to take from the esophageal motility evaluation with flip panometry. One is that flip panometry is consistently abnormal in achalasia, with reduced EGJ opening and an abnormal contractile response to distension. So while every abnormal flip is not achalasia, a normal flip can essentially rule out the presence of achalasia. Which segues into a second key point, and that is that a normal flip panometry is associated with a low probability for a major motor disorder. And we reported a study in which we identified 111 consecutive symptomatic patients that had a normal flip panometry that also completed high-resolution manometry. And the majority of these patients also had a normal motility on high-resolution manometry. And the remainder had high-resolution manometry findings, typically of inconclusive or uncertain clinical relevance. The EGJ outflow obstruction patients in particular almost all had normalization of findings on expanded manometry protocols, and those that completed esophagram were essentially normal. And importantly, none of the patients in this cohort had achalasia, nor were any of these patients treated with achalasia-type treatments. So in essence, the conclusion here was not that 70% of these patients were normal, but that in actuality, nearly all of these patients had normal esophageal motor function. And both of these key points are important when evaluating inconclusive manometries, especially the EGJ outflow obstruction classification, which can be a challenging clinical scenario, as this manometry can represent achalasia, but also can and frequently is a false positive manometry. We specifically looked at applying FLIP in patients that were classified with EGJ outflow obstruction on manometry. This is per Chicago classification version 3, and first used esophagram as the outcome, and demonstrated that when EGJ distensibility was normal, that is greater than 2 to 3, the retention of barium esophagram essentially did not occur. So this carried a very high negative predictive value, though there was some overlap with esophagram findings in the EGJ-DI less than 2 range. So additionally, we retrospectively reviewed treatment plans and symptomatic outcomes and found that these patients that had a DI greater than 3 that were treated conservatively, typically with acid suppression or as a functional disorder, they had symptomatic improvement on follow-up. Whereas patients with the reduced EGJ-DI, such as those less than 2, 9 of 24 were treated with LES-targeted therapy, and this included botulinum toxin injection, pneumatic dilation, POEM, and even Heller. And 78% of these patients had symptomatic improvement. The one patient with the worst treatment, here in this red line here, was treated with botulinum toxin injection and had a short-term initial improvement, but then followed with symptomatic recurrence. So overall, this further supports the role of FLIP to clarify the inconclusive or equivocal manometry findings associated with the EGJ outflow obstruction classification. And to briefly touch on using FLIP and EOE, FLIP can measure the luminal dimensions and the distensibility of the esophageal body, both of which may be reduced in EOE. The example shown here shows a study protocol in which the FLIP was performed both positioned in the distal esophagus, with the EGJ, stomach, and distal esophageal body reflected here, and then also repositioned in the proximal esophagus using the upper esophageal sphincter as a landmark to assess the remainder of the esophageal body, keeping in mind that the FLIP is 16 centimeters in length. And here we can see how the FLIP measures this esophageal diameter to be 12 millimeters and 10 millimeters, which can be applied to help gauge the size of dilation. Additionally, evaluation of the distensibility plateau measure in EOE was demonstrated to carry predictive value for assessment for the need for dilation and also the risk for food impaction. And within this study, demonstrating the increased risk with a distensibility plateau value of less than around 17 millimeters was associated with the food impaction. So in conclusion, FLIP manometry provides a useful primary and or complementary evaluation of esophageal motility. FLIP manometry is consistently abnormal in patients with achalasia. A normal FLIP manometry is associated with normal esophageal motility. And FLIP manometry can be beneficial to help clarify inconclusive manometries, especially EGJ outflow obstruction. FLIP can also help direct dilation and the risk for food impaction in EOE. Though also noting that indeterminate or inconclusive FLIP findings may occur, and that these may direct the need for additional evaluation with either manometry or barium esophagram. But overall, FLIP is completed during sedated endoscopy and thus is well tolerated by patients, and can also help complement and enhance the diagnostic impression provided at the time of sedated endoscopy, as well as can help direct endoscopic therapy or the subsequent management plan. With that, I'll conclude, and thank you, and we'll certainly welcome questions when the opportunity arises. Thank you again for having me.